Good morning, everyone. We're about to get started. I'd like to welcome you to the Mary Frances Picciano Dietary Supplement Research Practicum. I'm Regan Bailey. I'm a scientific consultant at the Office of Dietary Supplements, and I'm also an associate professor at Purdue University. So this is an event that we have been putting together for 10 years now. So you're getting the 10th version, and every year it gets a little bit different and a little bit better. So this started out as a 5-day, very intensive practicum, and due to changes in budgets and scheduling, it was really hard for people to commit to 5 whole days. And so we've tried to give you the most important information, but it's going to be very fast. We're going through a lot of talks, a lot of information very rapidly. So one thing I want to mention is we're not going to take a lot of time to introduce each speaker individually. We guarantee we've brought you the best of the best, and their bios are all in the binder so that you can read those at your leisure. So this practicum is named for Mary Frances Picciano. She was a colleague at the Office of Dietary Supplements who really developed this idea. Initially, she wanted to teach the teachers. So she brought in academic professors. She wanted to teach them how to teach about dietary supplements. Over those 10 years, this has expanded and really taken a focus on research. So we've opened it up to researchers, practitioners, anyone that is interested in this topic. Really, one of the most wonderful things about this event is your participation. We have it in this room so that everyone has a microphone so that you can ask questions. We have panel discussions whenever possible because that's one of the most interactive ways that you can talk with some of these experts in the world and really get your questions answered. So when you do use the microphone, please, they want you to have your mouth about 2 to 3 inches away from the microphone so that everyone can hear you. Just a couple of housekeeping items. There is a reception tonight at 5:30 at Lebanese Taverna. There are walking directions at the check-in desk, but you can also find it using Google Maps. It's pretty centrally located, and the food is really good. That's being sponsored by the International Life Sciences Institute, ILSI North America. So if you would like to say thanks to them on Twitter, we are doing a hashtag DSRP17. I realized I was the first one to use it this morning, so you haven't been busy tweeting yet, but I will keep checking and make sure that everyone's interactive. So I will use Twitter to keep everyone posted on what's going on. We have the Facebook group so that people can interact with one another. Something that I will really probably annoy you with is I'm going to constantly ask you to do evaluations. Every speaker has an evaluation link. And we take these very seriously. This is how we change the program every year in response to your needs. You telling us what works, what doesn't, what you need to know, what you don't need to know, helps us craft this program each and every year. So those are all available in the online binder. There's going to be 2 tours on Friday, and Louisa is here, and she will give you some more information on that later today. So before we start the program, I would just like to say some special thanks. First to Danielle Voss, the Practicum coordinator, who does an outstanding job keeping all of these moving parts together and coordinating everything with you guys. Luisa Rios Avila, she will be here later. She's helping someone actually get through security right now, but she's going to be taking over the practicum and has really contributed a lot. And finally, I'd like us to say a special thanks to our first speaker, Paul Coates, not only director of the office, but the provider of the coffee this morning. So he gets a very special thanks. And so what you'll find is that sitting in these chairs, while they're very comfortable right now, really gets long. So what I learned to do at some physical activity meetings is after every speaker, if you stand up and give them a standing ovation, you get to stretch, and these people feel incredible, especially because they're not here right now, so they don't know that they're not just getting a standing ovation. And it's really a wonderful thing to see. So I'm going to invite Paul Coates to come up and set the stage for this practicum. So thank you.
Many thanks, Regan. It's been a joy working with you on this practicum for all these years, and I know that you will continue to participate in a consulting kind of way, and you know that people are going to be calling on you at odd times for advice and input. So we're going to fly through some slides. Got your running shoes on? Because you're going to need them. I wanted to pay one piece of tribute to Mary Frances. Her picture's not up here on this slide, but the slide that shows up between talks or between sessions has a picture of Mary Frances in the top corner, your top left corner. And I'm always reminded when I see that picture how much of an influence Mary Frances had, not just on the staff and friends of the Office of Dietary Supplements, but for the larger nutrition research community. She's missed, but she's always with us. So I think she would enjoy the meeting that we're going to have today. Here's the start. 1994, the Dietary Supplement Health and Education Act was passed by Congress and signed by the President. And you will learn more about that from other speakers. But one of the things that it did was to define what's a dietary supplement. It's a product other than tobacco that is intended to supplement the diet that contains dietary ingredients. Some of them are fairly obvious as dietary ingredients: vitamins, minerals, amino acids. Others are perhaps not so obvious, herbs and other botanicals, which are not a customary part of many people's diets in the United States. And then a delicious category called other dietary substances, which gives you the sense that there was an awful lot that was being covered by the Dietary Supplement Health and Education Act. And the last defining principle was that it was intended to be taken by mouth. That said, some of the ingredients that are in dietary supplements are also in other commodities. Some are in cosmetics, some are in dog food, some of them are in foods, of course, and some of them find their way into drugs. There is a set of principles about how dietary supplements are regulated that I think Sybil Swift from the FDA will help you with. So just to give you a sense of the array of kinds of ingredients that are found, or products and ingredients in those products, they cover micronutrients, macronutrients, herbs, phytochemicals, zoochemicals, and others as well that don't obviously fit into any of those other categories. But it's a wide array. We don't know how many products there are in the United States marketplace. It's in the tens of thousands, and maybe you'll get a sense of why we don't exactly know the answer to that question. You'll learn a little bit about some of the resources that the Office of Dietary Supplements has developed and tried to provide for both the research and practice communities in trying to meet its mission of strengthening knowledge and understanding about dietary supplements. And we do this in a number of ways by stimulating, supporting, and sometimes conducting research related to dietary supplements and their health effects. We have a very strong background in developing research tools, and you'll be learning about a number of those as the days go on. We have an important role in evaluating scientific findings, and the reason we do all of these things is to help consumers and others who need to know about dietary supplements, what they can, what they can't do. And so part of our job, indeed, the end result of all of our work is to make scientific knowledge available for consumers and other stakeholders. You'll find examples of some of the products that we've provided on the table outdoors. You'll also learn that our website is probably the most important tool that we use in this. I'm always impressed when I learn how important that website has become in people's lives. We get 1.6 or so million visitors a month to that website, and they're mostly looking for information, and we certainly hope that they find it. Hope you do too. In terms of research, this picture only tells you that there is a lot of money that is invested in dietary supplement research by the National Institutes of Health, where we are today. And over the years that we've been tracking this, it's moved around a bit, but over the last several years, the investment by the NIH as an overall organization has been somewhere between $250 and $350 million a year. That represents about a quarter, 20%, I should say, of all of the nutrition research funding that the NIH conducts. So this ain't trivial. We think that's important because since 50% of the US population use dietary supplements on a regular basis, I consider that public health, and I consider it an important investment of public dollars to try to understand the issues in dietary supplements. Here's a bit of a scale thing. We Americans invest about between $35 and $40 billion the last year on dietary supplements in sales. So if that's $100, there's the NIH budget. It's $1. It's about 35. The investment is a lot less than that. And here's the budget for the Office of Dietary Supplements, which I don't complain about. Our budget is in the range of $25 to $30 million a year, and we use it for a lot of different purposes. But there's a scale thing here that you probably might like to be impressed about. When was the last time you saw a $100 bill, by the way? Or a dime that looked like that? Sales of supplements in the United States have increased pretty linearly since since the Nutrition Business Journal first started reporting these in 1994. And in 2015, the last year for which we have comparable data, the total bill was $38.8 billion. That's a lot of money that consumers spend. Put it in perspective, we spend $30 billion on books or book surrogates. We spend almost $39 billion on dietary supplements. That's about $100 a person. For comparison, we spend $300 billion on prescription drugs. We've spent $11 billion and falling on movie tickets. We spend about the same amount on over-the-counter drugs as we do on dietary supplements. And we spend a lot less than people still spend on tobacco products at about $80 billion. There's a whole variety of products in the marketplace. I mentioned there are tens of thousands of products, and sales are distributed among herbs, vitamins, minerals, sports nutrition, meal replacements, and other categories. Some of them are not dietary supplements for regulatory purposes, but for reporting purposes, the Nutrition Business Journal has put them all into this category. So the Office of Dietary Supplements has been operating for 22 years now. We first came into being in 1995. I've been with the office since '99. We've been guided by strategic plans for all the time that we've been in operation, and we think that's important. Big reason is that there are an awful lot of people involved in one way or another with dietary supplements, from consumers to researchers to regulators to people who develop methodologies for measurement of things in dietary supplements, clinicians, and so that gives us in the Office of Dietary Supplements something to do. And we've done this under the umbrella of a strategic plan for years. Our most recent one was released at the beginning of this year, and will cover our activities through 2021. I've mentioned what our goals are. This is a slightly different way of portraying them, but it's expanding the knowledge base in a number of different ways. We do this all in collaboration. We couldn't possibly do this work unless there were other people in the room with us, and these include other institutes at the NIH, other parts of the federal government, the private sector, the academic sector, and consumers. But we do this by expanding knowledge base, by expanding the workforce through training and career development, by developing research resources, and as I mentioned before, this is all in the service of translating into useful information for a host of end users, consumers, health professionals, researchers, and policy makers. How do we define our goals in what comes next? There are a host of questions that need to be asked, and we've been busy since the beginning. But generally speaking, what has driven us is, what's the public health issue? Are there currents in use of dietary supplements that we need to be tracking? I'll mention one briefly in a minute. Are there safety concerns that need to be considered? Have there been transformative events in the cultural space that have caused people to either use more or less of dietary supplements? So we try to monitor these for the purpose of identifying emerging needs for research. Among the things that we've learned that are pretty central to all of this is a measurement of nutritional status. And this applies largely to the substances in the dietary supplement marketplace that come from foods, but they also can come from other sources. But in terms of food and dietary supplement sources, it's important to be able to monitor nutritional status. And be sure that the measures of those things are reliable, and we've invested quite a bit in that over the last several years. And here's a knotty issue. What's the evidence for health effects of dietary supplements? It depends very much on who's looking, and so we have tried to be very neutral. I'm Canadian, and Canadians know where the middle of the road is, and I think that's why I've kept this job so long. But the point is that there are very strongly held views on health effects, both positive and negative, about dietary supplements. And we aim to try to tease through all of those opinions and sometimes sparse data sets to help people understand, so what is the evidence? And then we are always looking for ways in which we can fill the gaps in knowledge and translate the results. We do some of this by co-funding research grants with others at the NIH. You can't read this, but it reflects more or less the distribution, very much less than more, the distribution of use of products in the US marketplace, but it covers the landscape. It also, for those of you who are NIH savvy, the list on the right-hand side is the list of institutes that in 2015 we co-funded research grants with. And they might change from time to time, but it's generally in the line of sight of most of the institutes of the NIH. Another area that you will learn some more, and you'll learn a little bit more about this from one of our colleagues, Abby Ershow, who will guide you through some of the issues in research grant funding at the NIH. Adam Kuzak is going to talk to you a little later today about developments in our analytical methods and reference materials program that he has been working with Joe Betts on for several years, and you'll have the benefit of hearing from both of them today. And the goals of the program are listed here, and you'll get a fair bit more data when you listen to them. But it comes down to providing tools that can be used by everybody, by investigators, by regulators, by manufacturers, so that there can be a common platform for discussions about content of ingredients in dietary supplement products. We've used that increasingly to expand the field to address measurement issues for nutritional status. And the ones that have been most on our radar for the last few years have been vitamin D and omega-3 fatty acids. And with our partners at the National Institute of Standards and Technology, we've developed tools, again, that can be used by people who are practicing in the field. We've also mounted efforts related to databases, and you'll hear a little bit more about those. One database that, and this is just a number, last month, the Dietary Supplement Label Database entered its 65,000th label. That doesn't mean that we know that there are only 65,000 products in the marketplace, because we're still adding new labels at the rate of 1,000 a month. This is, again, an area where we collaborate. In this case, it's largely with the National Library of Medicine. You're in a facility here of the National Library of Medicine, and they've been constant partners with us on this development. You'll probably have questions about that database, and I hope that we can help you to answer them. A more deep dive database is the one called the Dietary Supplement Ingredient Database, which seeks to measure content of the most commonly used dietary supplement products in the US marketplace. Again, this is a collaboration, couldn't be done without our partners at the Agricultural Research Service of the US Department of Agriculture. And then finally, a project called the Computer Access to Research on Dietary Supplements, a database of federally funded research in dietary supplements that we've been conducting since '99. We do a lot to try to develop careers in this field, and we recognize that dietary supplements touch on a number of different disciplines. I've met some of you this morning already, and I venture to say that of the, let's say, 35 people that I've met, there are 36 or 37 or 38 disciplines that are represented. And that's because you come from different places, but the work that you do has something to do with dietary supplements. And we like to think that this practicum, along with other things that we do in the office, will be helpful to you as you're developing your expertise as a research scientist, as a teacher, in an analytical laboratory, as a pharmacist, in areas that I apologize I didn't mention, but we hope that this will be an opportunity for you not just to learn more about supplements in general, but also to make some contacts. We expect and hope that you will connect with one another, and you're absolutely welcome to connect with us. We do workforce development using all the mechanisms that we can think of. So there are NIH grant awards that serve the extramural community, people out in the universities. We also sponsor research within the walls of the NIH. We collaborate with others in the federal government to support postdoctoral fellows. We also offer opportunities for short-term training within the Office of Dietary Supplements. Examples are sabbatical leave opportunities or short-term training opportunities within the office, and then this practicum. End of the day, it's to communicate the science of supplements, and we're constantly called on by the media, by the public, and our efforts in this area have grown exponentially over the years. You will be hearing some of this from our colleagues during the course of the next couple of days. We have an evidence-based review program, and this is one of those programs that is probably right at the heart of things that we do. I mentioned that there are an awful lot of opinions about dietary supplements, and some of them are worth listening to. What I prefer is just the facts, and the facts can sometimes be brutally honest or brutally non-existent, and we have to be able to address the information out there. At the end of the day, it provides food for thought for us about what areas should we be investing in terms of research, but it's all intended to provide useful information for the consuming public. You have these slides, so I'm not going to go through this next part of it, because it really, I use vitamin D as an example. You'll be hearing about this and other examples as well during the course of the meeting. But what this has taught us, this systematic review or evidence-based review approach, is that there are issues in dietary supplement research that we can address, and we are addressing. Some of them are not unique to dietary supplements. Some of them are. But we take all comers, and we've used them in this slide and the next slide, and I want you to refer back to those slides when you get a chance, because these are at the heart of the kinds of questions that we want to be asking and we think you should be asking when you're evaluating literature, when you're constructing a research program, when you're thinking about what you're communicating. It all comes down to, what's the last bullet there and there? Measurement, measurement, measurement. And we've discovered that that is a central theme in all of this. So I'm going to stop there. You know where we live. Our website is given there, and we have an email address that you can always get us at. And it's a general email address, but if you have questions, whoever picks up the email will know who to send it to. So I'm going to stop there. I left myself a few minutes for questions and would be happy to answer them. I'll be around for on and off for the entire program, and we'll certainly be here at the end when you can grill me and see whether I can grill you back and see if you've learned anything. So thank you very much. Oh, that makes me feel so good. Are there any burning questions that people have at this point? It might be a little early in the game, but yes, ma'am.
Yes, hi. I was wondering if you could answer a question about the funding for that's offered and how much of that goes towards clinical trials versus other type of research. I don't know if you'd have a dollar amount.
I don't have it right off the top of my head.
But if you could say most or half or some, because it is quite a bit of funding, but it seems like clinical trials also consume a lot of funding.
Well, they do. And to give you a sense, there is a clinical trial that's currently going on called VITAL, the vitamin D and omega-3 fatty acids for the primary prevention of cancer and heart disease. This is run from the Cancer Institute. It's a multi-center clinical trial that comes from Brigham and Women's as the host institution. The budget for that trial is very large. It's in the tens of millions a year. It's starting to wind down now, and we're hoping that we will eventually see results from that large investment. But you're right, clinical research, one trial can take up the resources that might otherwise be spent on 20 or 30 or 40 smaller non-clinical trial studies. We always try to find a balance. And if I haven't mentioned this 10 times yet, I'll do it 11th time. We could not possibly do this ourselves. You saw that there's a host of funding agencies at the NIH with whom we collaborate. They don't need us to conduct that research, but we think that there is a lot more that we add being part of that research. The VITAL trial would have gone on, but we've invested a lot of money in that trial over the years, mostly to assure methodologic quality. And we do this selectively. We can't contribute to every trial. But the array of research, it goes from clinical research and population-based research at this end all the way down to botany and basic chemistry at the other end. Yes, ma'am? Any other questions at this point? Yes?
Yeah, so I was curious about what you had to say about reliable measures of nutritional status. So you've obviously done a lot of research on that. So what's the best way for me to find that? Like, I've searched and found your fact sheets for health professionals. So do I need to look nutrient by nutrient, or?
Yes.
Okay.
Yeah, and you will certainly get some more information about this as the day goes on.
Okay, thanks.
Okay. Well, I think maybe this is my opportunity to introduce back at you, Regan, one of my special colleagues who spent years in the Office of Dietary Supplements and now is at Purdue, but she's only a phone call away.
All right. So the purpose of my talk is really to set the stage for what you're going to learn this week, as well as to provide a very high-level overview of dietary supplement use in the United States. And as Dr. Coates mentioned, this story really starts here with the Dietary Supplement Health and Education Act. In our first session, we'll talk about the rules and regulations, and so I won't go too much into that. But what I want you to know is from the time before DSHEA till after DSHEA, we saw an increase in dietary supplement use, which is not as perceptible here. It doesn't look like there's a big change, but it was about a 10 percentage point change. And when you're talking about at the national level, that's a large number of people. And so I'll be using the National Health and Nutrition Examination Survey data to talk about some of the usage patterns in the US. So NHANES started in the 60s as a periodic survey and became continuous in 1999. And what that means is that each and every year, the CDC, National Center for Health Statistics, conducts this survey. So each and every year, and I call it one of our greatest national treasures. So not only does it have information on dietary supplement use, but I've just put a number of things on this slide. So whatever your research area is, this is a real data repository where you can get a lot of information and do research. So as I mentioned, supplement use went up after DSHEA, but really since the continuous HANES, we've seen it be pretty much consistent with half of adults using a product regularly in the last 30 days. We know that men use supplements less frequently than women. We do not see any gender sex difference in children though. About a third of children use a product. We know that supplement use patterns change with age. So you can see that use is high in 2 to 5 year olds and then decreases throughout adolescence and continues to climb throughout adulthood. And if I extended this age range further, it would just continue to go up. So use is very, very high, especially in older adults. So I labeled this slide the boring but important stuff. So to set the stage for words that we're going to be using, the word dietary supplement has a legal and regulatory definition. But oftentimes people use the word dietary supplement with a multivitamin product interchangeably because they are the most commonly used dietary supplement, but that is absolutely not the right thing to do. So I want to take a moment to unpack what is a multivitamin, what is a multivitamin mineral, and what is a multivitamin multimineral. And there's all different ways that you can do this. And because there's no standard definition, really people who have done work in this area operationalize these words very differently. So when you're looking at the literature, it's important for you to know what types of products that you are looking at. So there's different ways that you can do this. You take all the supplements and you put them into discrete categories. What some people do is count the number of vitamins and minerals in each product, and sometimes the percent that a product contributes towards the daily value is used in how these are operationalized. So I just wanted to show you an example here from the NHANES that I introduced earlier. The first paper is by Kathy Radimer. This came out in the early 2000s, which used the word multivitamin. So this was defined as 3 or more vitamins. Some work that I did at ODS, we thought, well, really we want to look more comprehensively. So we want to look at products that also contain minerals. So we developed 3 vitamins and 1 mineral, multivitamin mineral. And very recently a paper came out in JAMA that used the term multivitamin multimineral. So they operationalized it as 10 or more vitamins and minerals. So it seems like this is kind of silly and maybe not important, but when we look at how that characterizes the prevalence of use in US adults, we see this really does make a difference. And as I mentioned, a small percentage point on the national level means a large number of people would be characterized using these different products. And so certainly you can see that having no consistent definition makes monitoring trends over time problematic. And none of these definitions that have been put forth in the research community so far have taken into account how long people have used these products and how much they're taking. So that's another important dimension to measuring supplement use that hasn't really been captured to date. Nevertheless, I'm going to show you some of the work that we've done to look at the national landscape, first starting with children. As I alluded to earlier, about a third of children use products without any sex differences noted. In children and in adults, non-Hispanic white children are more likely to use products than other race ethnic groups. And supplement use increases with income. So this is a measure called poverty-income ratio. That's just a metric that was developed by USDA for how much money a family has based on how many people are in the family and where that family resides geographically in the United States. But the take-home message there is people with more money use more products. In children, children who are underweight or considered healthy weight are also more likely to use dietary supplements. And something that I found interesting is that children who use less screen time are also more likely to use dietary supplements. Children who already have health insurance are more likely to use these products. And so when I say health insurance, I mean private health insurance, not publicly provided health insurance. Among children, most users only use one product. So 86% report only using one product. And we'll see that's really different in adults. So by and large, these are the most common products used among children, the multivitamin minerals. So 1 in 4 children in the US uses a multivitamin mineral supplement. So this is taking all children and doing a percentage. When we look at just children who use supplements, you'll see that 80% of them are using this product. So it's a different way to ask the same question, basically. Moving on to adults, I've already told you about sex differences and age differences and race differences. So I have this here just for your information, but we don't have to belabor the point. Similar to children, supplement use increases with income. Interestingly, in adults, there's no longer an association with BMI, weight status, and supplement use. But we do see that adults who report moderate to high exercise are more likely to use these products. Supplement use is also associated with a number of healthy behaviors, so not smoking, using alcohol in moderation, and even people who report their health to be better. And this is one of the things that makes studying dietary supplements very problematic, because there's all of these behaviors that are tangled up together, and if we see a beneficial health effect, is it really a supplement, or is it all of these other behaviors that are contributing to the outcome? So think about that as you listen to some of the talks that we have here today. What's interesting is that only half of adults who use products use one. So this is a pie chart showing that what I thought was probably the most striking is that 10% of adults use 5 or more products regularly. So 1 in 10 people use 5 or more supplement products regularly. And that contributes to that $100 per capita per person estimate that Dr. Coates provided earlier. So when I was taking this practicum the first time, I thought, so what? You know, people are using these, who cares? Well, most people are using a multivitamin or multimineral supplement, and those contain about 100% or more of the daily value of nutrients. So if we don't look at the nutrient exposures from dietary supplements, we're really underestimating exposure. And that's what I find most interesting. So in this slide, I have the dose is the poison. Obviously, too little or too much of just about anything can be detrimental. And if you believe this and take what I say on faith and flip this over, you'll really see how the National Academy of Medicine has developed the dietary reference intakes. And you'll hear these throughout this practicum, so I just wanted to take a minute to explain them to you. So the lower end of that, you know, we're concerned about risk of inadequacy is the estimated average requirement. So these are people we're worried about who are not getting enough. And then the other side of that coin is the tolerable upper intake level, or the UL. These are people that we're worried about getting too much. This is where we would like to see most of the population. But here is where we make public health decisions. And so I'll show you some data there. But before we characterize the diets of adults as at risk for inadequacy or excess, we want to make sure we're getting at usual dietary exposures. And we know that we measure often the diet in a daily dose, so a 24-hour recall. How representative is a one-day report of usual intake? And so we need usual intakes in both public health monitoring and surveillance, so who's getting enough, who's not getting enough, because those dietary recommendations that I showed you on the previous slide are intended to be met over time. If you don't meet the DRI for vitamin C for one day, you're not going to get scurvy. But is your vitamin C, your usual intake of vitamin C, enough to prevent a deficiency? It's also important, though we're not going to talk about it extensively, but when we relate dietary exposures to health outcomes, you want to make sure you're getting habitual intake before you relate that to some sort of health outcome. The problem is that usual intakes are not directly observable. And so we measure them with dietary assessment methods that we know have error, which can bias the results. And it's probably beyond the scope of this particular talk to talk to you about the statistical methods we use to adjust short-term intakes for habitual intakes. I want you to know that that is something, if you're interested in, we can certainly talk about. So I hope I've convinced you that we not only need usual intakes when we're evaluating the nutritional landscape of the country, but we also need total intakes. So from supplements, and even some prescription and over-the-counter medications have nutrients in. So when you want usual and total, you have to look at nutrients from all of these sources. So I'm going to go through a couple of slides with bar charts just to give you broad brushstrokes of what's going on in America. So this is all Americans age 2 and older, so percent less than the EAR. So these are, we would be concerned about risk of inadequacy. So this first estimate is from naturally occurring. So before the addition of enrichment or fortification, this is the percent of Americans 2 and older who would be likely at risk of inadequate intakes for selected vitamins that I've shown you here on these slides. When we look at the impact of enrichment and fortification, we see big drops, especially for things like folate, where folic acid is added to our food supply. And then further, when we add the impact of dietary supplements, we see that these drop even lower. Okay, so in this slide, what I'm showing you is users and non-users combined, remember? So these are going to be different estimates if we looked at them separately. This next slide, I'm showing you the same thing just for some other vitamins so that you get the sense of the impact of not only enrichment and fortification, but how supplements can affect certain things very differently. So for things that are very low, like riboflavin, dietary supplements aren't going to budge that needle very much. But for other things where we have a higher prevalence of inadequacy and we have adequate use of supplements, it really does move the needle. So I'm just going to show you a few selected minerals here, the same setup, naturally occurring, and really we don't see much from enrichment and fortification for minerals with the exception of iron, okay? But dietary supplements, again, really lowers that risk of inadequacy. So I told you a lot of things about people who use dietary supplements. They're older, they're more likely to be women, they are more likely to be white, higher education, they exercise more. What about the way that they eat? Is that different? And I'm not going to bore you with a ton more bar charts, but I've really summarized in this slide. For adults, people who use dietary supplements tend to already have better nutrient intakes from the diet alone before we even factor in dietary supplements. And I have those selected nutrients here as well as the reference if you'd like more information. But just to show you an example. So this is now in blue, adults, this happens to be women, but the same phenomenon is observed in men, the percent who are considered inadequate who do not use supplements. In this next bar, we're looking at supplement users, but only from their foods, not even including supplements right now. So you see they're already at a lower risk, so a lower number, lower risk. And then when we look at users with their total intake, you see a really big difference, particularly for something like calcium. So 71% of women who don't use calcium supplements are at risk versus 24% who do. So in this slide, I'm just looking at calcium across age groups and what a dramatic impact that has because the calcium requirements increase with aging. So for women who are not using a calcium supplement over the age of 50, almost 90% have intakes that would be considered at risk for inadequacy. And even with the use of dietary supplements, we still see that about 25% to 30% of women. And that's because there's not a lot of calcium in multivitamins minerals. Calcium's big, it's hard to fit into a pill. So if you look at a typical multivitamin mineral, there's about 100 milligrams of calcium, and that's not going to budge the needle that much. So whenever anything goes down, the other side goes up, right? So in this next slide, I'm going to show you percent of intakes that we're worried about excessive, so above the UL. So what's interesting is that no adults exceed the UL from foods alone. It's only from the use of dietary supplements. And this is by sex here, but you can see it's anywhere from about 3 to 12% depending on the nutrient. So this is risk of excess. That's really different in children, and let's talk about that next. So this slide, I'm showing you children 2 to 8 years of age, users and non-users separately. So there are no differences in the dietary intakes of children. As I mentioned in adults, adults who use supplements already have better diets. That's not that's not the case in children. So I'm trying to simplify now and just show you users and non-users and the prevalence of inadequacy. There was no difference in whether or not children who use supplements had inadequate intakes for these nutrients because there was simply no inadequacy to begin with. So if you don't have any inadequacy, adding more nutrients for supplements can't make you any less inadequate, right? Now moving on to older children, what you'll first notice is that there's more differences presented here on this slide. So we start to see that as children age, there are more differences in whether you use a supplement or not, and especially in the prevalence of inadequacy. There were no differences for these nutrients here because, as I mentioned, there was very little inadequacy to begin with. But what was striking to me and what I'm concerned about is that calcium and vitamin D intakes are low, even with the use of dietary supplements in this group. And then moving on to our oldest children, 14 to 18, I could not fit all of the nutrients for which there was a difference into one slide, so we have them on 2 slides. From the work that we've done, this is a very high-risk group in the United States. They have the lowest supplement use, and they also tend to have really low dietary diversity and low exposures to different types of vitamins and minerals. So there's a higher prevalence of inadequacy in this age group than in younger children, and supplement use is low. But in those adolescents and teens who use supplements, it really makes a big difference. So what I told you about adults is you don't really see anyone exceeding the UL from the diet alone. That's not true for kids. Look, you'll see in dark purple, 17% of children 2 to 18 are exceeding the UL for zinc just from their diet alone. But these numbers get to about half of kids for vitamin A, folic acid, and zinc when we're talking about supplement users. We're going to have a whole talk on this, but why are people using these products? There's a lot of really interesting work going on here. And I don't want to steal the thunder from Johanna Dwyer, who does an excellent job giving you that information in this talk, but I will say that it's not because it's being recommended by a healthcare practitioner. So only 15% of products in children and 23% of products in adults are used based on the recommendation of a healthcare practitioner. And that's most commonly a multivitamin mineral or calcium. So people are using these products because they make the choice to use them. No one's telling them to use them. I'm just gonna wrap up with some recommendations that are out there. So there's a recommendation that postmenopausal women have calcium and vitamin D. Any women of childbearing age be exposed to folic acid. Women and men over the age of 50 to consider a B12 supplement. Iron is a nutrient of concern, especially during pregnancy, and of course any condition that impairs digestion, absorption, and metabolism of nutrients, we should always recommend a dietary supplement. Here are some specific recommendations. AAP is the American Academy of Pediatrics. They recommend that exclusively breastfed children receive vitamin D. Of course, any children with a compromised intake due to any number of reasons, they recommend a nutrient supplement. AND is the Academy of Nutrition and Dietetics. They are a professional group for nutritionists, and they recommend anyone with poor nutrient intakes, low-calorie diets, and anyone who avoids certain types of foods. So anyone who is for religious or cultural or ideological reasons, not having a certain food group, you're really limiting dietary diversity. For example, if you're not having dairy, if you're lactose intolerant, you may be missing out on calcium, vitamin D, some minerals. So that's a time when we would consider recommendations for dietary supplements. So I'm just going to end with a few take-home messages, and we will be here all week to answer certain questions that you have. But I want you to really understand one of the main reasons that we do this is that supplement use is widespread in the United States. We see consistent predictors in both adults and children for the use of dietary supplements. I told you that adults who use dietary supplements already have better diets, but not true in children. So we saw from a number of those bar charts that dietary supplements do help people who use them to meet the recommendations, but they also can increase the risk of high exposures. And what you'll see is throughout the course of these 3 days that currently there's very little available evidence for the use of supplements for the prevention of chronic disease. That doesn't mean that they don't do anything. That just means we don't have any evidence, and we'll talk about some of the limitations in them. So I'm happy to answer any quick burning questions that you may have with regard to this very rapid overview of supplement use in the United States.
You mentioned that there's challenges in isolating the effects of some of the dietary supplements amongst all of the other behaviors. Is it slightly easier to do that isolation when we're talking about deficiency or mitigating deficiency versus, optimal amounts?
I would say that there's very strong evidence that in nutrient deficient populations that the addition of dietary supplements is beneficial. We see that in developing countries. What I'm talking about here is the US context, where we're typically looking at already adequate diets and adding more nutrients to already replete diets. Is there an additional health benefit? And that's what people are really trying to uncover. And so we have traditionally looked at that from an epidemiological lens, because we have the data that's available in large number of people, but we have all of those behavioral things that I talk about that can confound that relationship. Ideally, what we want is a clinical trial. Those are often limited to 5-year funding cycles, and some of the impacts of nutrients might have much longer latency. So it's really hard to study supplements for a number of these reasons.
Great, thank you.
Okay, I think we're ready for our break then, and we'll come back and we will start our first panel session on the rules and regulations. Thank you.